correct one in 6 out of the 8.
Yeah,
So
man,
that means you get rid of
You
the rest of
put
the
my name
department.
there.
You swept it, right? Like
Hardware equipment changes?
Do I do what?
Do you put in work
You should-
orders?
there's a way to just say.
It's the government.
Well,
Gosh, you don't
the
have to
do-it-yourself
paint like a
thing.
it's white.
so-
Yeah.
Maybe that's better. Maybe, isn't that better?
Yeah, I think so.
Instead of putting
Like
a
a-
bulky,
No, but I like this.
Non-shiny,
you
yeah.
like that?
It has to be high though, because it goes really high, so.
Well, that's okay, because we can change the zoom. I zoomed out the screen. Anyway, sorry, Linda, go ahead. Start.
Sure.
It is what it is,
So
and I need
this
to do a round, so.
is my Morbidity and Mortality conference. I forgot the slide, but everything's confidential, names have been taken out. So the objective of this presentation is to evaluate when we should prescribe dental or mouth guards for elderly patients, discuss the importance of communication among interprofessional teams, and we're going to look at a literature about dental devices in the elderly. So what I'm going to do is lay out the timeline and the sequence of events, and then after the case has been presented, then we'll have, I'm hoping, more discussion about what we could have changed or what could have been done better. So this centers around a longtime CLC patient. We had noticed that he was having decreased oral intake, he wasn't eating very much. He's relatively young, he's 52. He suffered an anoxic brain injury. I was told during a procedure, something happened with anesthesia and he wasn't able to get oxygen to his brain. And ever since then, he's had been very severely cognitively impaired. So he can talk, but more on the level of a severe dementia patient. So his answers to questions are very unreliable. He's also got paralysis, very difficult to, he's got contractures, can't really move, he's pretty much bedbound. And then he has the other medical problems like heart disease with blood pressure and CHF. So we had noticed that he wasn't eating very much, and generally when you have elderly patients who have decreased oral intake, one of the first things you do is just simply assess their dentition and their oral care. When we evaluated him, it was noted that he had some what we call aqueous ulcers, or just the little white ulcers you get from inadvertently chewing your cheek when eating. And so we had the geriatric dentistry look at him and evaluate him. They made some recommendations like triple mouthwash, more oral care, and they fitted him with a mouth guard. They called it a maxillary soft acrylic guard. And they recommended putting it during the day in between his meals and at night to keep him from biting himself. So that was on the 14th of October. And he was fitted and that order was placed, and they educated the nurses on how to put the guard in. He had the guard in his mouth for roughly a week, and as I was going to my car, I get a page about how they can't find the guard. So we go back and we're looking everywhere. We checked the bed, checked the floor. You know, the first thing you would do if you're missing something. The nurses were concerned that he may have swallowed the guard. So the charge nurse and I went and talked to the dental tech, and the dental tech was saying that the guard would appear on an x-ray, because that was our concern, was if it would show up on an x-ray. So it was my first time dealing with something like this, where we have like a guard missing. So I ordered a KUV, in other words, imaging to look at his stomach, because I was thinking, oh, he swallowed it, it may have ended in his stomach. And I put that I was looking for a foreign body. Well, radiology saw that order and called me and said, are you sure you don't want imaging higher up as well? And suggested like a chest x-ray, not just the KUV. We also did your typical physical exam just to make sure he hadn't swallowed it. So we looked in his oral cavity, we listened to his lungs. He didn't have any stridor, he didn't have any outward symptoms. He was talking, he was eating, swallowing, and he wasn't in any distress. We did try to ask him, and as I mentioned earlier, he had severe cognitive impairment, so one person asked him if he'd swallowed it, he said yes. Then when you asked him, oh, so you swallowed it, he'd say no. So it was really unreliable as far as getting information from him. So we ordered the x-rays, and they're here, and they commented that they couldn't find any foreign body. And mentioned that he had some low volumes, that possibly an early infiltrate was also occurring. Now, this is a patient who has chronic dysphagia, who has chronic aspiration pneumonia, so we weren't too impressed, and we were pretty satisfied that we didn't find the guard. They said pretty much the same thing on the abdominal imaging, that they couldn't find a foreign body, and they commented on his stool burden, because he also suffered frequent bouts of ileus. So this was all read in the afternoon. Later overnight, in the early mornings, he had a temperature of 105, and the night nurse gave him Tylenol. Now, normally his pills are crushed, and she said she noticed that when he was swallowing it, he was grimacing. So she brought it to our attention, and she placed his medications on hold. And the medications that were on hold, he just basically took DocuSane, Tylenol, PRN. So we went to evaluate the patient. Again, pretty much nonverbal, really can't tell us if he was having any symptoms of cough or having any throat pain. The only thing I noticed was a bit of nasal congestion heard when he was breathing, but I didn't notice any stridor or any respiratory distress. And the nurse commented he was grimacing when he was swallowing, and this is a patient that suffers from chronic dysphagia. There had been talks about putting a peg tube, but that wasn't even an option because he has a different anatomical structure. So even if his family members had wanted to pursue a peg, which had been brought up in the past, so it wasn't an option. So I wrote my assessment on him, prescribed just a steroid spray for the congestion I noted. Noted that the mouth guard was still missing and that we didn't find anything on imaging, but that we were still having a low threshold for pursuing more studies if we thought that he had swallowed it. The abdominal imaging had noticed increased stools, so we did an enema, and he did have a temp, so we were concerned for aspiration pneumonia, so we were going to keep monitoring that for any changes in his mental status. Since they were complaining that he was grimacing with the Tylenol, I asked the speech language pathologist to just see him again. She knew his case, had been following him. She saw him that morning and pretty much said that it was just his chronic dysphagia. She knows that it's a little difficult to assess his swallowing because he was having a prolonged oral prep time, and she did note that he did grimace when he was swallowing. So after she evaluated him, we decided to consult ENT, and this was early morning. We called up ENT, we quickly looked at the imaging, we explained to them what had happened, and they weren't too impressed with the imaging and the fact that he didn't have any physical findings, because they always ask, is there stridor, is there respiratory distress, like any of the common symptoms you have when there's a foreign body suspected. And they said that they would evaluate him later that afternoon, because they had more emergent cases to see. So ENT came in the afternoon, and with the Flexic or the instrument they have, they were able to see that he had the mouth guard in his oropharynx. It was pretty much up and down, like hooked on the back of his tongue. So this explains the symptoms of pain, swallowing, the grimacing he was having, and by the afternoon, he had started to have increase in salivation and some rhinorrhea. So in other words, just some more nasal secretions. They tried to take it out there, but since he was biting on the bite guards they have, they determined that it would be the best and safest thing would be to transfer him to the ER and take him to the OR under sedation and then take it out. So they took him to the OR that evening, and they were able to take it out of the posterior oropharynx. Then he went back that night, and he was developing a cough. So given that he had a temperature earlier that morning, we did your typical workup again. We did blood work. He didn't have any increased white counts, no leukocytosis or left shift indicating an infection. He hadn't fevered since then, so he was pretty much stable. His vital signs were stable. He did have a low blood sugar of a glucose of 36, and the nutritionist was recommending that we start parenteral nutrition. So because we were having difficulty keeping his sugar up, and because we didn't feel comfortable starting that on the floor in CLC, we had well, we also did some imaging, sorry. This showed that in comparison to earlier, when he was having an early infiltrate, it showed worsening atelectasis and then worrisome for pneumonia, the left lower lobe disease. So because of these findings, we called the hospitalist and had the patient admitted. And this is just the notes summarizing the past 24-hour events in which, you know, he was having a fever, we couldn't find the mouth guard, he was taken to the OR. It's just a summary for the admission note. So he was admitted and treated for aspiration pneumonia. They were uncertain as to when he developed the pneumonia. And so he received antibiotics, and ultimately he was discharged back to the CLC where he currently resides. So complications with this case, well, it was a dental guard was placed in an elderly patient who has an anoxic brain injury, and we'll go into the pros and cons of that. And that in itself was a complicating decision. Another issue was just that this person didn't have any signs of stridor or any physical exam findings to indicate that he had anything lodged in his airway. Another complication throughout this timeline is just that x-rays were ordered under the impression that we could see the imaging after we talked to radiology in the dental department, but it turns out that it doesn't and didn't show up on x-ray. Another issue is, or could have been a possible issue, is just that we consulted ENT in the morning, but that we didn't get an evaluation until later that afternoon. And there's a question of if the aspiration pneumonia was caused by the mouth guard being lodged in his oropharynx, or by undergoing sedation in the OR, or just from his typical comorbidities and disease. So some issues that occurred throughout this whole timeline was just that there was a lack of communication between nursing and staff, miscommunications with the radiology and the dentistry department, because we were unsure about if the dental card could have been shown up on the x-ray or not. And you could argue that there was a possible delay in care with the ENT coming in the afternoon, although if you look at the timeline, all of this happened in less than 24 hours. I tried to do a literature search about guards in the elderly, and I know that when this case came up, we talked to the dentist and the dental department, and they also did their own literature review, and they really couldn't find anything against putting mouth guards. I found tons of articles on how important it is to evaluate elderly and dependent patients for oral care, especially with decreased oral intake, as in this case, but I really couldn't find anything about putting guards in. So I feel like this case was one of those zebra cases. I put this quote in: when you hear hoofbeats, don't think zebras. And it's basically talking about how when you have a problem in front of you, you should look for the simplest, most common explanation, which I feel is how we initially started. I mean, a mouth guard's missing. You look in the bed, you look around the room. You don't automatically assume that it's lodged in the back of the throat when you don't have any signs. But I feel like if I'd been looking for zebras, it might have been a different story. Things I've gone over in my mind about how things could have gone better or could have been prevented is, the one thing I think is maybe if I had done the ENT consult immediately that afternoon. I just don't know, because in my mind it could have still been in the bed or in the trash, or like I didn't have any outward signs that this patient had the guard in the back of his throat. And I didn't have any physical findings of it. So I wanted to leave it open for just discussions on how you feel this could have gone better, or what could have been done differently.
I mean, we talked about it at the time, like right after it happened. And I think, you know, had I been in your shoes, I would have done the same thing as well. Because you looked for the right stuff. You looked for the stridor, the drooling, none of that was there.
I mean, clinically, you know, especially initially, it seemed to sound okay, like, that's,
I was involved in the case too, so not that evening when he you were first called, I was called the next morning. And the nurses were very clear, they said, he's changed. He's changed from his baseline. Something's going on. And at that time, there was still a lot of, like, okay, I'll go see him. But I didn't trust them as I should have. And maybe if I had just listened to them a little bit closer, I would have probably urged Auntie to come like right then. Because I'm able to do that when I was an attending or whatever, or send him to the ER to get evaluated within 1 or 2 hours. So that's what I take home, but that's after everything that I learned, you know? But I remember them telling me like straight in the eye, you need to, something's different. So that's what I take with this case. It's like, if somebody tells me who knows them better, I should listen and trust, you know? That's what I think. But that's after I have all the evidence, you know?
Well, but it's hindsight
It's
is
hindsight.
hard, I mean.
But that's what I still have learned. I'm like, okay, maybe I should, because I was like dead set. I was like, there's nothing wrong. I was just, we did what we did, you know, there was nothing wrong. But that's hindsight. But, you know, but that's what I take from it, you know?
Yeah, not being familiar with the case since it happened before I ever
Yeah.
got here, I was impressed with the 24-hour timeline from someone in a nursing facility to actually having it, being in the OR and getting it taken out. And that's probably one of the unique qualities of having a CLC that's attached to the hospital. If he was in a community place where there's the physician's not there every day
Yeah.
and don't have access to all those consultants, it could have been a much worse outcome.
Exactly. Like when I went to see him it was like 2 o'clock, they said, okay, he's getting worse, Dr. V, he's different. I went and he was literally like Ryan Maria and salivating. And I just like, my jaw dropped. And then I called the NT, I was like, okay, you need to come now or I'm gonna send you to the ER. And then they came within like 10 minutes because they heard that I was like, okay, you need to come now, you know? So it was like, it changed a lot. You weren't there because I think you were in class already. And but I remember that his physical exam did change, you know, but in the beginning, in the morning, he was dry. Like, he had a little bit, but not enough to be worried. By the time I saw him, there was like obvious, I was like, okay, now I know. No one has to tell me that it's not in there anymore.
What's surprising is how can you talk, drink, eat, swallow with this
I
hanging on the back
know,
of your
and we were lucky that he did it.
How is it just not like continuously cough?
Exactly.
I mean, it's one of those ones that, like, you know, I like aspirate like a small amount of like coffee and I'm like hacking for 20 minutes afterwards and he's got like a mouth guard stuck.
Yeah, and when he showed it to me,
Well, that's probably part of his brain injury.
Yeah.
Have the reflex system.
when the ENT showed it to me, and then I could see it with his light, and it was like that. Like I could see like that much of it, and it
So
was
how
like
did they get it out?
it was like this.
The OR?
Yeah, they took him to
Grip it
the
and
OR.
pull it out.
But I actually saw it, and I was like, but we couldn't see it on our exam because we went with our.
With the
But when he went in a little deep, with his.
But I mean, that was something that they hadn't even seen before, right? Like, I mean,
No,
that was
they haven't.
news for them. This wasn't even a common
But
occurrence.
it was so funny because the nurses were like, I told you so. Like, they would just love it. I was like, I know, you're right. You know, it was because they kept telling me something. It's in there, Dr. B. It's in. Remember that?
But all of this is sometimes a process issue. This is a
Exactly.
patient too, who we don't typically have a patient with mouth guard down in the CLC. Some of it in preventing, I think we have to think of not just how would we respond, but maybe how could we have prevented this from happening. Were we really doing what they told us, how dental prescribed it to do between meals and at bedtime? When did that actually fall back in there? Were we documenting that we were taking it out and putting it at the right time? So to me, it's not just how did we respond to it, it's did we create a process for this patient that needed something monitored? Did we document what we were doing? Because they couldn't find the mouth guard either. I mean, I think you look everywhere like you said, but it doesn't seem like we're really following any kind of steady process to track what we were doing with this thing that was unique for this patient.
Wow. And I know the wife was not happy and said that you should never have put the guard in.
Who was that?
The wife.
Oh.
Wasn't the flip side of that, though, she wasn't happy with him chewing on his cheek either, right?
And that had been going on for a long time.
Yeah, it's like, why did they put it now if it had been happening for so long?
So then there's the issue of should you put mouth guards in elderly, demented, or severely impaired patients?
Now my boob is done. My boob is
Well,
done. For what?
My observation is, first of all, it's quite impressive that this thing could be lodged in the back. The other thing is, my first impression when I first heard the story is whether or not this mouth guard was flexible or rigid, or if it's possible to even go down, which way it's going to go down. Just think about more and more the mechanical parts of how this is possible. But
I mean,
Sherry's
it must have
right.
been fairly loose
It's pretty flexible and probably very moldable kind of a
to
plastic.
come off the teeth, or, I mean, I don't know.
Right. So,
And when we spoke to dental, they said that they stand by that you can put, and that the mouth guard was appropriate, and said that it's nursing education, that, it should have been, it wasn't put properly in.
I think what was interesting is remember when we told them, well, okay, it was opaque, right?
Yeah.
But you told us it was, that you could see it. And then they were, I think in the middle of all the chaos, they changed their story too. So it looked like, that was interesting too, that dynamic.
Yeah, and that taught me to document everything, that I should have
Maybe.
documented all that.
Yeah.
All the imaging was very focused on, like, center of the chest, stomach, and we kind of, like, whoever was shooting the film
Yeah.
wasn't kind of thinking, okay, where is this coming from? It's kind of starting at the top and working its way down. Because if it was in the stomach, it's like, we're probably not going to do anything. Whereas if it's kind of somewhere from the mouth down into the chest, that's going to be a bigger problem. But, I mean, plus the thing was going to be overlaid with all the teeth and all the bones in the skull,
Yeah.
and so it's going to be...
even if you get the pharyngeal x-rays, I don't think you could have found that.
Right, exactly. It may have been hard to find.
Teaches you that the body cavities are pretty good in accommodating to anything that's put in there. So you think that physically not possible to store in the oropharynx, but yes, it's possible. So, have you seen any ENT literature or anything about how big of an items that they see?
How big of like a foreign body they've
Foreign
seen?
body that they
They
have
said
taken
this is the
out?
first time they've seen anything like this.
Might even want to publish it.
I'm sure they did.
At least that is something.
I'm sure they
I'm
did.
sure that they
Well, but you should do it together, put it in a
Yeah,
ENT journal.
I mean, it'll be a learning case. If it is for us, then it'll be a learning case for everybody,
You've already done all the work,
Right.
pretty much
Yeah.
75% of the work you need to do and you're
Because there's nothing in the literature that definitely would get published.
Right, and definitely targeted more to like JAMDA or something like
Right.
that. Because even if ENT posted in the ENT journal, it's like, it's not
Yeah.
like we're
I
gonna
mean,
go and
yeah.
turn to that literature. Whereas, if it goes into a journal, it's gonna go to people that work in nursing homes. That
Yeah,
would be
I'm sure
sensitive
you'll
to
see
it.
that a lot if they start using it.
Well, especially like hearing aids, because you think like, okay, mouth guards are probably uncommon, but like, I've had patients where like they've had, an EGD done for some unrelated thing, and they found a hearing aid that's in some various stage, like decay down in the stomach, and nobody ever knew it was gone or whatever.
Last thing you need is a lithium battery down your throat. That's pretty bad.
Another complication was the aspiration pneumonia. So do you
Yeah.
think this was caused by the mouth guard? Do you think this was caused by sedation in the OR?
It could be anything, right?
Yeah.
He's
I
already
mean,
has this
They
stage.
had the early infected.
If this whole scenario never even happened, he could still, just with his history of dysphagia, he could have had aspiration pneumonia, so.
And he had it in the past too,
Mhm.
even not related to this event.
Yeah.
And it could have been even just a mechanical manipulation of physically getting it out during the procedure, spreading out bacteria, that kind of thing too.
And putting it in.
Another thing I was a little unsure about is if I should have done the speech language pathology evaluation. Because in my mind, I was thinking, oh, he's grimacing with the Tylenol, this is just a flare up of his chronic dysphagia. So he needs to be evaluated for dysphagia again. I wasn't thinking, oh, he has a mouth guard lodged in the back of his throat. So, they did that evaluation with, they didn't know the guard was there, but they reevaluated him for dysphagia, and I'm wondering if that should have happened.
I don't think they can do it bedside. The only time they probably could have picked that up is if they're in trouble or something.
I think that's very reasonable. I think, like you said, you didn't know a mouth guard was lodged in the back of his throat. For all we knew, it was accidentally thrown away in the trash or something like that.
Well, and that's Yeah.
You know, I think it was a very reasonable step from a person who knows him, has worked with him before as a speech pathologist who knows him very well. I mean, it was another way of getting some information about what might be going on with him.
I think the one thing I found, like when I was a resident, and I still feel now, is like I don't know how medical school physical diagnosis, they teach you how to like look in the ears, they teach you how to do a slit lamp, which you need like, $100,000 of equipment to do, and yet though you never learn how to do like the ENT, like basic throat exam with the mirror. It's like, you have to go through like 6 years of ENT residency to be able to look in the back of somebody's throat with a mirror. And it seems like if we knew how to do that, it would have been one of these things we would have just done it right away, said, oh my God, I think there's something back there, and it would have changed the way we did this. And, because the whole ENT consult was really just, can you look back there with a mirror or fiber optic to see what's happening back there?
Right.
So how would this change your practice if you got a call about a form or like a guard missing? Like, would you just order imaging first, or would you send to ER, or?
We'll call ENT and say, we had a case before.
I don't want to say it. I know. I have PTSD.
I know this sounds very unlikely, but this is what happened.
I want you to look down there.
Well, you know,
I
from
will
an
not
ENT
sleep.
standpoint, regardless of whether or not it's happened, if you call them in the middle of the night, they're gonna be like, is he drooling? Is there stridor?
Yeah,
I'll see him in the morning.
Yeah.
So, I mean, you're kind of very limited by what they're gonna be willing to do, and your bad experience is not gonna affect them coming in.
But I do like Cherry's idea also that, can we be more proactive in identifying these cards missing? Like each meal, have we put it on and off properly, and then, so that we're more like timeline, okay,
This is when, because they really
It's
didn't
less
know
than
when it
8
was
hours.
We don't
missing.
really know when it went missing. Or
Yeah,
when
it
was
hasn't
there,
been
how long
missing
it
for
was
1
back
hour
Yeah.
or 2 days. We didn't know, we just
We didn't
missing, we don't know. I mean, it shouldn't be more than a shift when it's,
Yes.
That's a really good point, because I didn't even figure out, because
That's
that's
a
not
good-
charted.
Because, I mean, I think so
Yes.
often we blame ourselves about how did we
I know,
not
I
find
blame
this
myself.
sooner? Well, I think sometimes we have to think, well, how could we have prevented it in the first place by, developing a process when somebody has something that could put them at risk or unique to them, and we need to be thinking about it all the time. I mean, if we don't usually put, quite frankly, a checkbox or something that has to be documented, we don't always stop and think, okay, where is that mouth guard right now?
And I guess some key points that I'm just disclosing here, I was also a little worried about just the litigious part of this, because the wife is a millionaire from having sued because of the anoxic brain injury during the procedure. So then, she gets called about this guard in the back of his throat, and she's upset, and there I am trying to figure out and look back at my own documentation, and I hadn't documented the names of the radiologist I spoke to or the dental person I talked to about the guard and about it showing up. And so it kind of taught me that I should be more careful about how I'm documenting things, especially when things go wrong or like an outcome is bad. I mean, this patient's still alive. I mean, ultimately, he got the aspiration pneumonia, but I don't know if that was caused by the foreign body. The foreign body was ultimately removed, but it could have been worse. He could have gotten airway compromise and died. Or
I missed it. Is he still using the mouth guard?
No, we never looked over
Okay.
it. We're like, we never listened.
Yeah, he's attached with a little
He's-
string.
You sprayed it with a
Well, that's
radio
what the
pack.
dentist said. Remember, she said that maybe in the future we'll make mouth guards with an
But she said she
attachment.
was going to keep doing these devices, like that there was no literature against.
I don't think the design is the fault. I think what Sherry said about keeping a meticulous log of when was the last person who put the guard in and observe that it's put in, and then from that moment on, if it went missing, then you know it could not have gone anywhere else but inside the body. So that
But
way.
then, but the type of patient you put it in, I started to also think about, maybe he
Yes,
wasn't the
if
right
he's
patient.
nonverbal, and also the fact that he cannot complain or explain to you what's happening, put him at a much higher risk as well. So.
And it taught me that when a specialist makes a recommendation, we don't necessarily need to follow it either. Like maybe it's,
Yeah,
like maybe I should have thought, hey, this isn't a good idea, even if it's recommended.
Yeah.
So I was thinking a couple of things. So I have a mouth guard. It fits really tightly in my mouth. Like, it's pretty hard to get out. Like, it kind of
And he can't
hurts,
move
you
his
know.
arms, so this was all.
So I'm just thinking, like, how did, you know, I'm kind of thinking, like, how did it jar me? And maybe what you're saying about making sure it really snaps in place and so forth. But it also just reminds me, I mean, I have several cases from my experience where I feel like, gosh, you know, things weren't that bad until I started monkeying around, and then I sure made them worse, you know. And so you take what is surely a bothersome issue, him biting his cheek, you know, but you try to solve it, and then you kind of create all of this. And like I say, I have several cases in my own experiences where I just think, gosh, if I had left low enough, left, somewhat bad alone, it would have stayed somewhat bad instead of gotten, But I think we have pressure sometimes from families, from others
Do something.
to do something, don't just stand there, do something, and sometimes you need to don't do something, just stand there, and so it's a good reminder for me about that, because I think we're all kind of conditioned to, want to fix and want to help, and I mean, this poor guy, he's got an exit brain injury, and and yet sometimes when we start doing that, especially in a really complex patient, there are just higher risks for these outcomes, and so for me, it's a good reminder to really think about first do no harm, and I don't know if I would have perceived this to be a potential risk of this intervention, but to think about before we start, like you say, just because somebody recommends it, I don't, as the primary, I don't automatically have to just check off and say, okay, let's go do that, so I think that's a really good point. I love that picture on the top right. She is just, and the bottom right. Oh, she's got.
She's gone all over the U.S.
She hasn't
Yeah,
gotten
just a
sick
video
from
point.
from hospital. She hasn't not got sick from traveling.
She has a lot of frequent flyer miles already.
$2 million mile.
Well, she flies with mom.
Thank you for bringing it to our attention. Good case.
All right, thanks.
Should write it out.
Anybody else can sign in? Oh, got it.
Well, they're gonna be doing the makeup and stuff, starting at 7 or 7:30. So I'll go there first. I don't know, I'm probably gonna take my daughter.
It's a big class.
Yeah, I know, I thought about it.